So as you've heard about, the Revivint TC Live procedure by Bioventrix basically is aimed at patients with ischemic cardiomyopathy, but a specific subset of patients, particularly with anterior transmural infarction, with either severe hypokinesis, akinesis, or dyskinesis of the anterior wall apex, and perhaps some of the distal inferior wall and the septum. And by basically putting in a series of anchors in a hybrid procedure, which is done between an interventional cardiologist and a cardiac surgeon through a transeptal puncture by the interventional cardiologist and through a minimal left lateral thoracotomy by the surgeon, this technique is able to exclude in a minimally invasive way the left ventricular akinetic or dyskinetic segment, which by Laplace's law decreases wall stress, decreases left ventricular volume, and should improve efficiency of ventricular contraction without significantly worsening diastolic dysfunction. That's the goal. So to test this, Bioventrix, working in concert with the FDA, came up with the U.S. pivotal trial. This is a prospective multi-center pivotal trial in 120 patients. This is a non-randomized trial with a 2-to-1 patient allocation. Patients who are eligible for the procedure, there'll be 80 of those patients, will be receiving the live therapy and treated with maximally tolerated guideline-directed medical therapy, while a similar control group, which I'll be describing, 40 of those patients will be treated with guideline-directed medical therapy alone. And patients will be followed for the 1-year primary endpoint and for 5 years total. The hypothesis is that in patients with anterior scar and symptomatic heart failure, live therapy will significantly and safely improve heart failure symptoms, quality of life, and exercise capacity, prevent death and heart failure, readmissions for heart failure. And it's, again, my privilege to be the co-principal investigator of this study, along with Andrew Wexler. Jerry Estep is the co-principal investigator and has made sure we're doing everything right in terms of heart failure, et cetera. So the key inclusion criteria are the presence of a focal discrete scar involving the mid to distal anterior wall and or apex. It can be akinetic or dyskinetic. Again, it's septal, anterior, anteroapical, or anterolateral. The ejection fraction has to be less than 45%. The left ventricular end-systolic volume index must be increased, greater than 50 mLs per meter squared, and patients have to be in NYHA class 3 or 4 despite guideline-directed medical therapy. These are 2 examples of ventricles that would nicely qualify. The key exclusion criteria are unresolved thrombus or mass in the left atrium or left ventricle, a pulmonary hypertension, prior pericardiotomy or open surgery, and significant functional or degenerative mitral regurgitation. Now, the control group must meet all the entry criteria except for one of the following. Either they have undergone previous pericardiotomy, left thoracotomy, or open heart surgery, or the LV aneurysm or scar location does not permit treatment with the study device, or the patient elects to be enrolled in the control group. So the patient basically just does not want to be included. But the control group can have these other exclusion criteria, that is contraindications or inability to adhere to systemic anticoagulation, known hypersensitivity or contraindication to device materials, previous pericardomy, left thoracotomy, prior surgery, significant pericarditis, et cetera, et cetera. So the primary effectiveness endpoint is the 12-month rate of a responder analysis. So it's basically the freedom from any hospital readmission for new or worsening heart failure and improvement in Minnesota Living with Heart Failure quality of life score by at least 10 points, and improvement in 6-minute walk distance by 25 millimeters, and improvement in New York Heart Association class by at least 1 grade. And of course, the patient has to be alive to meet those criteria at 1 year. So all of those have to be present, and of course, the control arm will be compared with the therapy arm. Then there are 2 primary safety endpoints. I won't read them in detail here, but here they are. So currently, of the 120 patients, 110 have been enrolled, 77 in the treatment group, 33 in the control group, at 27 actively enrolled sites. So we're coming up on the 120 planned patients. So in summary, reducing heart failure in patients with large anterior MI represents a major unmet clinical need. And there's no doubt that the Revivint TC therapy can markedly reshape the left ventricle, and in many patients will substantially reduce LV volume and improve ejection fraction. In the large scale, we didn't get to talk about this for time, but in the large scale randomized stitch trial, surgical ventricular reconstruction with CABG was safe but did not improve outcomes compared with CABG alone. Possible reasons include suboptimal patient selection, inadequate volume reduction, or postoperative diastolic dysfunction, and we've tried to overcome those in the ALIVE trial. As a result, because of this, surgical vascular reconstruction is weakly supported by the guidelines and is rarely performed. It also has substantial mortality and morbidity associated with it. So the bottom line is that the live therapy now, which is a lesser invasive approach, which as you've seen from the earlier presentations, has been associated with an excellent safety profile, and in many patients, substantial improvement in both left ventricular geometry, function, and clinical outcomes is now undergoing this investigation, and we hope to have these results for you in probably about a year and a half. Thanks very much.